Assalamu alaikum. My first pleasure to be here. Second, my task in the coming few minutes to convince you that you can use DCB and CTO successfully. I'll just walk you through several cases and I hope it will be of educational value. So first patient is 54-year-old man with progressive short breath over several years. He was found to have severe calcific aortic stenosis bicuspid valve, plus 3 vessel disease. He was refusing surgery for 3 years. We tried to convince him. He went to many hospitals. Then for compassionate indication, maybe we decided to do TAVI and target the BCI. So after deploying Allegra valve to his calcific bicuspid aortic valve, we went ahead trying to address the LAD, which is chronically occluded for at least 3 years. So we use the contemporary measures to cross that lesion with specialty wires, microcatheter support, and then we double check that we are in the distal vessel by microcatheter injection. Then we went ahead dilating this LAD, and I'd like to show you the final result, the immediate final result. You can see it's not very impressive. There is some dissections, the flow is not very optimal, but you need to hold your horse, for these complex diffuse disease vessels, and you need to avoid oculostenotic reflex. And we discharged him in good condition, maximum medical therapy, and he came back after 1 year. And see how his LAD has grown, the section was healed, and there are new lesions that maybe were not addressed in the previous angiogram. So now you can use targeted stenting to that mid-segment focal stent and avoid extensive stenting if you will go by stenting from the beginning. So the vessel became bigger, the dissection healed, and new lesion can be addressed either by another DCB or stent. Second case, patients with classical angina. He has CTO of the LAD. As you can see, the stenosis started in the proximal segment involving ostial big diagonal. Again, with the multiple attempts. First, we protected the diagonal with a soft wire, then we managed to go through this totally occluded LAD and then start balloon dilation. And probably you can appreciate how small and diffuse the disease and how much dissection that we have. Very, very small vessel, it's LAD. So, I don't think any one of you would probably consider putting stent in this diffuse disease small vessel. So what we did, gentle DCB, from the proximal to mid-segment, and then we sent him home on maximum medical therapy to be reviewed in 3 to 6 months. For whatever reason, he came back just in 1 month for another indication, and his treating physician was very anxious about his LAD, so he was taken to the cath lab in just 1 month time, which was not our target. And you can see his LAD definitely has grown. Now you can identify the lesion. The ostium of diagonal is free of disease because of the DCB that we used. And the bifurcation, there's no significant stenosis. So significant improvement only in 1 month. We decided to leave him like this for time being and bring him again in 3 to 6 months' time with clinical follow-ups. So as you can see, DCB allows late sealing of the residual dissection, promote favorable remodeling of the uncaged vessel wall. I'll take you to a more complex case, 65-year-old, post-renal transplant, renal impairment. He came with angina. You can see big ramus artery that is occluded. You don't want to use lots of dye. You don't want to commit him to prolonged dual antiplatelet because of risk bleeding and other issues. So we went ahead with the standard technique to wire this ramus. And now we're between putting stent and running the risk of geographic miss, or use DCB and see. So we decided to go with DCB, and you can see his result. It's a stent-like result. We don't have follow-up cath, but we have clinical follow-up. Patient did well and clinically very stable. So DCB definitely saved less dye, less complexity, and good outcome. Fourth case, which is more of major bifurcation, 80 years old, known to have diabetes, hypertension, hyperlipidemia, previous MI to the RCA, presented again with ACS. And this is his left system. You can see there is severely diseased ostial circ. And the stent of the, if you can appreciate, there is late filling of the distal RCA because of severely stenotic, severe ISR. So now we need to decide what technique with regard of ostial sac, which is probably the most difficult lesion that you deal with. Again, you don't want to geographic miss. You don't want to put a stent hanging in the left main. You don't want to miss the ostium. So we decided to consider DCB as our primary strategy. We need to prepare this lesion very well because of heavily calcific segment. So this is the initial balloon dilation. You can see undilatable lesion. So we went ahead with shockwave, and I would like to highlight the technique that we have used to this in this patient, because you know the shockwave is bulky balloon, so it's not easy to push it in a tortuous vessel or acute angle. So we could not push the shockwave over this ostial circ. We could use other technique like use extension catheter or use anchoring balloon. But what I did here, I pushed the shockwave balloon all the way, trying to engage the beginning of the stenosis or the calcification and start shockwaves at that level. And with progressive dilation, sequential shockwave pulsation, managed to cross that lesion. And then we did IVAS that showed cracked calcification. And this is the final result, stent-like result, and avoided caging this vessel or missing with this ostium. So just a few technical aspects with regard of DCB use in CTOs. We need to have optimal lesion preparation. We need to not overreact to dissections. No flow-limiting dissection maybe is better, associated with better outcome and better healing in the future. We need to prepare the lesion very well and not to be afraid of using scoring balloon, shock waves, or even rota, even if you are planning DCB as a primary strategy. So optimal lesion preparation is of paramount importance, and drug-coated balloon angioplasty need meticulous attention to the technique to make it very successful. Thank you.